Let's talk about the monitoring in anesthesia. Now, basically, the American Society of Anesthesiology has given the monitoring guidelines, and they have divided the ASA monitors into 1 and 2. That is ASA standard monitors 1 and 2. The ASA standard 1, it is actually the anesthesiologist itself, because the person who is conducting the case is constantly looking at the monitors and patient clinically. So that will be the first standard monitor, and all the other monitors are the ASA standard 2 monitors. In the 2.1, it is for oxygenation. It will include 2.1.1 is the oxygen sensor, and 2.1.2 is the SpO2. Usually we only talk about the SpO2 as ASA standard monitor. Oxygen sensor, in earlier times we had to calibrate the oxygen sensor. It was a galvanic fuel cell which was first calibrated on room air with a FiO2 of 21% daily. It was done daily. In modern anesthesia machines, it is auto calibrated, and then it is also calibrated 8 hours after. What was the reason? It was the reason that in GA the shunt increases, so the FiO2 need increases, and there are other causes of increase in FiO2 requirement by the patient. So that is why we had to calibrate the oxygen sensor daily. The 2.1.2 was SpO2. So this becomes the ASA standard 2 first type of monitor for the oxygenation. The second monitor in the standard 2 is 2.2 is ventilation, that is ETCO2, end-tidal CO2, also known as capnography. 2.3 is for circulation. It includes 2 monitors, ECG and non-invasive blood pressure, and the timing which is set for the non-invasive blood pressure is at least 5-minute interval. 2.4 is the temperature probe for temperature monitoring. So these becomes the ASA standard monitors. But remember that in anesthesia we have, based on a particular case, we have several other types of monitoring. Let's at least enumerate them and see what are the possible scenarios where we can use those monitors. That completes our list of monitoring in anesthesia. Then we'll discuss about the ASA standard type 2 monitors, that is SpO2, ETCO2, ECG, NIBP and temperature in a bit detail as well. These are the ASA standard 2 monitors. The other names are for invasive BP monitoring. We have arterial invasive lines that we secure in whatever artery you can think of, most commonly in the radial artery, because it is superficial and there is very less neural structures and less chances of damage to vital structures around the radial artery. So we usually cannulate radial artery for invasive BP monitoring. And you must remember the terms like Allen's test and modified Allen test, which is done along with that. So that there is less chance of the ischemia to the distal hand if we cannulate. If there is less collateral circulation, we should avoid putting the arterial line into the radial artery. Then we have a bispectral index or the entropy. These are basically the monitors for depth of anesthesia. As you know that in usual day-to-day life, we do not put the patient for this bispectral index or entropy, because we measure the vitals and we look at the patient clinically. But it is very obvious that how can you even imagine what is the exact concentration of anesthetic, the IV anesthetic or inhalation or combination of them at the CNS level? You cannot measure it by looking clinically. So that is why we needed some measure for EEG monitoring. This is electroencephalograph. This EEG that we all know, that we have alpha, beta, gamma, delta, these types of waves. Now these waves are actually simplified and converted into a number. This number may be either a BIS number, that is bispectral index, or it may be a entropy number. They are very, very similar, very slight difference, but obviously it is a different topic to talk about it in detail. But this was the basic, that it is a simplified version of EG to tell you the depth of anesthesia. And you should remember a value of 40 to 60 is the value for BIS for general anesthesia. Then we come on to the neuromuscular monitoring. This is again consists of a lot of other variables, most commonly being the train of 4. Then we come on to the CVP monitoring. This is central venous pressure monitoring, usually set as a part of major surgeries, like when we expect major fluid shifts and we want to give vasopressors or inotropes to the patient. The pulmonary artery catheterization, a lot more invasive monitoring system as compared to CVP monitoring, but it tells a hell lot of more variables, maybe 10 to 12 variables, which include cardiac output, may tell you the temperature, it may tell you what is the fluid responsiveness of the patient and whatnot. Then there are cardiac output monitoring setups. It may be less invasive, like non-invasive, semi-invasive, and a lot invasive, where you put arterial line and central line and use those methods along with algorithms to calculate what is the cardiac output of the patient, and is very complicated, and it in itself is a huge topic to talk about. Then we come on to the somatosensory evoked potentials and myo-evoked potentials, usually done in surgery close to nerves like scoliosis surgery. Then we have POCUS monitoring, that is point of care ultrasound, where we can use the ultrasound at bedside to see if any intervention is required, or what is the exact clinical scenario where we can put other lines. Suppose you want to use ultrasound for nerve blocks, you want to use ultrasound for uh, checking the airway, the difficult airway scenarios. Then we come on to the ICP monitoring, the intracranial pressure monitoring, used in neurosurgery patients, where we put a cannula into the ventricle of the brain, and that will measure the intracranial pressure. So these actually covers most of the monitors that we use in anesthesia. Let's talk about the 5 standards. The pulse oximeter we have already described in the previous video. You can check the pulse oximeter video in on the same channel. Let's talk about the end-tidal CO2. It has a waveform which consists of the baseline like A to B. This is actually the beginning of expiration, and when the patient expires, it will have the dead space air coming in. This will increase the curve to B to C. Then there will be alveolar air which will be emptying out, will be gradual increase till D, and this D point is the point where we measure the value of the end-tidal CO2. Post D, the patient inspires, and as it inspires, obviously the CO2 will decrease in the circuit. It will drastically fall and come to the baseline. This waveform, the variations in the waveform will tell you what is the reason for the increase or decrease in the end-tidal CO2, and it has a lot more clinical significance just on the basis of what is the shape of the curve. Then we come on to the ECG. The ASA standard monitors tell you only 5 lead ECG, and it has filter selection is important. There are 3 types of filter in the ECG: diagnostic, monitor, and filter. The diagnostic mode is for ST analysis, the monitor mode is for the rhythm monitoring, and the filter is for reducing the electrical artifacts. Then we have a modified leads, 3 lead system. Suppose you don't want to put 5 leads, the surgery demands placement of lesser leads, then we can use a modified lead, 3 lead system. Let's move on to the blood pressure. The blood pressure, already know that a non-invasive blood pressure is based on the oscillatory method, and this is how it calculates the mean arterial pressure. And the last one is the temperature monitoring. where you can measure the mean temperature, the core temperature, and the thresholds for shivering. GA lowers the threshold by 2 to 3 degrees, and you have to maintain intraoperative core temperature of 36.